Hi everyone. So let's talk about a little bit about diabetes today, okay? So here is a picture of the islets of Langerhans, which are in the pancreas. We have our alpha cells and our beta cells. Our alpha cells produce a glucagon, which increases our blood sugar, and beta cells produce insulin. So with diabetes, typically it's a problem with the beta cells, and they are not secreting enough insulin to help open those cell gates to take the blood sugar into the cell. We have three types. We have type 1, type 2, and gestational. So type 1 diabetes, it used to be called juvenile diabetes. It is typically it typically occurs when in young children, and it is considered an autoimmune. So they don't really know why this occurs. It's some type of, they believe it's some type of genetic factor. However, even though it might run in some families, we actually don't have enough data yet to kind of prove that. It's a more of a theory, very good theory, mind you. But they typically say it can be triggered. So you might have this in your body, but it needs to be triggered. And so it could be an environmental issue, maybe an allergen, or if you have a virus that could trigger it. But it is an autoimmune response that attacks the beta cells, and those beta cells are the ones that produce the insulin for us. So with type 1 diabetes, eventually the beta cells just stop working, period. And so we have to supplement with insulin. Type 2 diabetes, some of the causes are lifestyle, obesity, inactivity, and age. Some medications can cause this, and then also metabolic syndrome. We're going to go over metabolic syndrome, but basically it's in the same category as lifestyle and obesity and inactivity. And we'll go over that. Type 2, though, really, if you think about it, is a normal disease process when you age. So someone that is, let's say 80 years old, their body reacts differently now due to the aging process, and they've used their pancreas their entire life, and so things just start to slow down a little bit. So someone that is older, it is a kind of a normal process to get type 2. Obviously, not everybody gets type 2 diabetes, but it is not uncommon whatsoever for the elderly client to have some type of mild type 2 diabetes. Where it's not normal is when a child, adolescent, middle-aged, or adult gets type 2 diabetes. That's not normal, and that is from their lifestyle and them overworking their pancreas, their beta cells in their pancreas. It's from overworking them because of the sheer amount of carbs that they're eating. Gestational diabetes, you'll talk about this in OB. What I just wanted to point out is that they check you when you are having a child, when you're pregnant, for gestational diabetes. They do a special test. And sometimes, though, most of the time it goes away after you give birth, but sometimes it can stay. So even though you get gestational diabetes, you do have more of a precursor to continue to have, let's say, type 2, in the form of type 2 diabetes, but it was triggered from pregnancy. So let's go over the pathway a little bit, and some of this is repeated, but it's just repeated just for your knowledge. So glucose, if we want to kind of review this, glucose in our bloodstream, we want the insulin in the bloodstream to open up the gate, open up the door for the glucose in the bloodstream to enter our cells. And that's how we get our energy. Okay. They're stored all throughout our body, as you know. And what we'll get to the liver in a second. I should probably put this down. But if there's a problem with the insulin and that gate not opening, then we're not going to get enough energy. We're going to be very tired, and our blood sugar is going to be increased because it's not where it's supposed to be. So it keeps storing up in our bloodstream rather than going into our cells. Okay. So the liver is very sensitive on insulin levels. And what happens is that the liver stores glycogen, okay, which is a form of glucose. It stores it. So it's this backup plan just in case there's something goes wrong and your blood sugar drops. Typically, the pancreas or the alpha cells in the pancreas will typically stimulate the conversion of the stored glucose in the liver or glycogen and convert it to glucose so that it can then be released into the bloodstream. So if someone's blood sugar is low, has a very low blood sugar, the alpha cells, the pancreas and the liver work together, and the alpha cells stimulate that conversion. The process of the conversion from glycogen to glucose is called glyconeolysis, and that just converts the glycogen to the glucose. And then, of course, that increases your blood sugar. When we release our insulin from our beta cells, the insulin binds to the insulin receptors on the cells that allow it to open, which then allows the glucose to go from the bloodstream into the cells. So inside our pancreas, we've already talked about this a little bit. We have our islets of Langerhans, and we have our alpha cells. So they release the glucagon to increase our blood glucose, and then again they stimulate that stored glycogen in the liver to convert to glucose. And then our beta cells release our insulin to decrease our blood glucose by taking that glucose and putting it into the cells. When we have high blood sugar, our pancreas releases that insulin from the beta cells. And one note to make is that potassium goes with the glucose into the cell. Okay, so when we get to DKA, diabetic ketoacidosis, if the glucose is not going into the cell, then what's left over in the bloodstream is glucose and potassium, and that's one of the reasons why the patient in DKA becomes acidic and acidotic. Okay, so when the glucose goes into the cell, the potassium follows. Okay, low blood sugar, again, our pancreas releases the glucagon, and then also the glucagon tells the alpha cells tell the liver to convert. This is a pretty nice diagram of the whole process. So in this particular diagram, we've got our normal blood sugar here, 70 to 110. And if our blood sugar starts to rise, the pancreas releases the insulin. The insulin is uploaded, opens the gate to upload the glucose into the cell, and then we have homeostasis again. And then vice versa, if we have some low blood sugar, our pancreas releases glucagon, and then our liver comes into this as well, and it breaks down the glucagon and returns it to that bloodstream in the form of glucose. So with type 1 specifically now, we talked about an autoimmune, how it's triggered, sometimes a virus, they really don't know. And we have that destruction of the beta cells. So that means that no insulin at all. So this part here does not work. The insulin does not work. And therefore the glucose cannot be uploaded into the cells, which then keeps our blood sugar high. Okay, we not only have high blood sugar, but we also have increased levels of potassium. Now, what happens is our body does not like that. So our body wants to dilute this blood because it's full of glucose and full of potassium. And so what it does is it releases fluid then from the cells to the vascular space. So as you remember when we're talking about the cells, if we're releasing fluid from the cells, we could get some cellular dehydration, right? And so we have fluid in our vascular system because it's being diluted, but our cells are dehydrated. Our body then thinks it's hypoglycemic due to no energy in the cells. So it's this vicious circle. So there's no energy in these cells. And so the body wants to increase the glucose in the body because it thinks that it doesn't have any, whereas that's not the truth. What's really happening is that it does not recognize the fact that it's just missing insulin. Okay. So the pancreas goes ahead and releases more glucagon to increase that blood sugar. But that's not what's needed. So it's this vicious uptake of glucose in the blood, and there's no energy going into the cells. So this cycle at the bottom here, this hypoglycemic cycle, keeps happening over and over and over again, drastically increasing that blood sugar. Now, with that increase in blood sugar, this is a difference between type 1 diabetics and type 2 diabetics. So medications, some of these are both for type 1 and type 2. And we'll take a look at this in a moment. Type 1 has to use insulin because they don't produce any. But sometimes type 2 patients also use insulin. And when you look at this in the hospital, we use a sliding scale. This is just an example of a sliding scale. So we've got here, if your blood sugar is less than 70, then we're going to initiate the hypoglycemic protocol. And we're looking at different dose scales here. So low dose, moderate, and high dose. And the doctor will decide which one is best for the patient. They might not choose the right one at first, and they might need to change it. So you need to monitor their blood sugars and make sure that the scale that the physician uses is appropriate for that patient. And then as you can see, 70 to 130 is 0 units, 131 to 180, we would give them 2 units. Now the sliding scale, all it does is it is to decrease that blood sugar from the elevated value. So let's say from 180 to 120, just for example. Okay, it does not take care of any food that they're going to eat. It only takes care of their higher blood sugar. Okay. And then, of course, as you go down the scale, it says greater than 400, 12 units, and call MD. So this is just an example. They're not all the same, but it's very close, but it's just an example of a sliding scale. So remember, the sliding scale only takes care of the high blood sugar and tries to put it into a normal blood sugar value. Okay, and that is the sliding scale. So we have things called basals, boluses, and prandials. So a basal is a constant. So if someone is just doing shots, that would be like a long-acting insulin like Lantus, for example. So Lantus gives a basal dose, which means that it slowly, it's not given the insulin is given all at once, Lantus, but it is a slow release insulin. And so it brings that blood sugar down constantly for approximately a 22 to 23 hour period. Okay, so if someone's running normally at 240s, it might bring them down to like the 180s. But as they eat, their blood sugar is going to go up, and then they'll need this sliding scale. A bolus is the sliding scale, basically. So a bolus can be a couple of things. It can be this sliding scale, which is to bring down elevated blood sugars. A bolus can also be in the form of a prandial dose. So a prandial dose is a dosage of insulin that is predetermined by the physician. So maybe, 3, 4, 5, 6, 7 units, for example, to cover the carbs they're about to eat in their meal. Okay, so let's say my patient is 180 for their blood sugar, and I'm going to give them 2 units of the let's say regular insulin, depending on what the scale can be regular insulin, it can be Novolog or Humalog. So let's just say regular insulin. So I'm going to give this patient 2 units of regular insulin to take their blood sugar from 180 to maybe 120. And then if it's lunchtime, because we usually do it before meals, right, AC, then depending on the amount of carbs that it has been ordered by the physician, we will give this prandial dose right before they eat. And that will take care of the impending elevated blood sugar that they're going to get from the meal that they're going to have. Okay. There's also insulin pumps and continuous glucose monitors. So insulin pumps come in various forms and sizes. I believe on the next slide, I'll show you pictures, and then continuous glucose monitors. So I'll just show you those on the next slide. For medications, we have PO anti-diabetic medications, and I'll show you that on the spreadsheet when we go over them. There's also dextrose 50%, 25 grams IV push. So if a patient has low blood sugar and it's severe, the blood sugar is severely low, and they cannot take anything orally or they are unconscious, then we would need to give them dextrose 50%, or D50 is what we call it, and that's 25 grams IV push. So that goes in the IV, not subcutaneously, and that will then bring up their blood sugar. Glucagon can sometimes be ordered, however, and that's 1 milligram IM. However, that's not the preferred method in the hospital because in the hospital, the patient's going to have an IV, and so we're going to give them D50 IV push. Glucagon is good for home use, for family members to use at home if the patient's, if their loved one's blood sugar goes low. If they are alert and oriented and not disoriented, and safe to take orally, then we can give them 15 grams of glucose in the form of orange juice. So we don't want to give them a peanut butter sandwich, even though that's high in glucose. It needs to be fast acting. So we need to give them juice, or we can give them glucose gel.